Here's Dr. Gil Lederman, New York's only Harvard-trained, triple-board-certified radiation cancer doctor. If chemosurgery or radiation isn't working or isn't tolerated, when cancer and its pain and symptoms aren't getting better, seek a fresh second opinion at Radiosurgery New York's Urgent Cancer Consultants for innovative, custom-tailored cancer treatment. See our experts within one business day because we know your time and your life are precious. Our goal is proper diagnosis and effective, non-invasive outpatient treatment. Decades of leadership, first in New York with brain radiosurgery, first in America with body radiosurgery for cancers of the brain, body, and prostate, all custom-tailored for you. Call 212-CHOICES, 212-CHOICES for a prompt appointment and free booklet DVD. Super convenient, 38th and Broadway, with most insurances, Medicare, Medicaid accepted. You're next at Radiosurgery New York. Just call 212-CHOICES, 212-CHOICES.
1991, my father, who you know I adored, we just lost him a year and a half ago, we brought him to Dr. Lederman. You need to bring yourself or someone you know who needs to have the barnacles scraped off their backside to get their rear in gear and walk in there right now because Dr. Gil Lederman is New York's only triple board certified Harvard-trained radiation oncologist, first brought the non-invasive stereotactic body radiosurgery to America, and he's got the longest experience treating cancer using radiosurgery. So look, do yourself a favor. If it's cancer-related, and I'm talking breast, lung, pancreas, liver, kidney cancers, and more, you got to bring it to Dr. Gil Lederman. He'll send you an informative booklet DVD. You watch it first, you read, you sit down one-on-one with Doc Lederman, and then you prepare for what it is you want to do and you should be doing. Just call Dr. Gil Lederman at 212-CHOICES. Set up that appointment today, 212-CHOICES, or set it up for someone you know won't do it for themselves. At 212-CHOICES, that's 212-CHOICES.
Welcome, everybody. It's the Radiosurgery Show with Dr. Gil Lederman, MD, New York's only Harvard-trained, triple-board-certified radiation oncologist who brings you the latest cancer treatment news, interviewing world-renowned cancer experts, delving into special cases, and, of course, answering your questions. I'm Rob Redstone, broadcasting from the WABC studios in the heart of New York City. And now, please welcome Dr. Lederman.
Hi, good morning. It's Gil Lederman. We hope you had a great week, and we're back here to take your calls and talk about cancer information and health information. We have a lot of news from the week, and we have a lot of patients to discuss. If you have questions, please call us at 1-800-848-9222. That's the WABC studio. Russ will answer the phone, who's running the program today. That's 1-800-848-9222. So I want to talk about actually great news first. A patient who came in this week, a gentleman who is 79 years old. He's a divorced man with one child, and he was fine until 10 days ago when he developed a large, hard mass in his right cheek. Now, this mass sticking out of his cheek on the right side, the size of a golf ball. It was so big that he couldn't open his mouth. He saw his primary doctor, and his primary doctor referred him to me. I saw him on Tuesday, and we got him worked up immediately. The primary doctor thought he had a colon cancer that had spread to the cheek. The patient did have a history of smoking. He stopped smoking a couple years ago. Now, his weight was stable. His last PSA was fine. I examined him. He had this very hard mass by the mandible on the right side, size of a golf ball. His mouth itself was fine, and the rest of his exam was fine. He was pretty much convinced he had cancer, bad cancer, as was his doctor. So we got him worked up. We got a scan, and we did a little needle biopsy immediately. It's painless. You just stick a little needle in and suck out some cells. And guess what? pus came out. He had an infection. He had a big abscess in his masseter muscle, the muscle that helps you open and close your mouth. He had an abscess, no cancer. He is so happy. And he remembers when I was talking to him, I said, look, this could be an infection. We don't know that it's a cancer. So not everyone with a big mass has cancer. Had he not come in, he most likely wouldn't have known what he had. His doctors elsewhere were convinced it was a cancer. So he is happy. We can drain that, give him antibiotics, and most probably he will be A-OK. So for him, it's great news. Not every mass is cancer. That's why it's best to give us a call. If you have a question or a lump, if you're concerned about having cancer, give us a call. It doesn't have to be cancer. We can get you worked up in a jiffy. Like him, he came in. Everything was done the same day, and he had reassurance the same day. Wow, is he happy? He came with his brother. His brother's happy. His doctor's happy. The whole gang had their life turned around so quickly. And yesterday I saw a man 52 years old, married, who has newly diagnosed decreased hearing on the left side. On the left side, sounds are muffled, so when he listens to the phone, it's not clear like the right side. He has ringing in the ears for 10 days. He has a pressure sensation in the ear. But no other symptoms. His face is fine, his mouth is fine, his walking is fine, he's fully functional, he's very strong. He's a court officer, so he's very strong. And on exam, he has decreased hearing on that side. He had an MRI done, which showed a small tumor in the auditory canal. The auditory canal is where the nerve goes from the brain to the ear. It's where that nerve, the 8th cranial nerve, lands. Now, the 8th cranial nerve is one of the more common nerves to have a benign tumor called acoustic neuroma or vestibular schwannoma. This man has that. In the past, people had surgery. We know with surgery, most all people end up deaf in that ear, and many, many have damage to the facial nerve so they can't move their face. So this man has a friend who I treated years ago with acoustic neuroma who's done great, and that's how most all of our patients with acoustic neuromas have done. They've done great. We were the first in New York to do brain radiosurgery, which is focused beam radiation, so we can just hit the tumor and not hurt healthy tissues. We were the first in New York to do fractionated brain radiosurgery, which is non-invasive treatment. So unlike the Gamma knife, which has 4 screws that go through the scalp into the skull and is painful and it gives just one treatment, we stopped that technology in 1993, by the way. So it tells you how long we've been at that. We stopped what other people are just starting. We stopped it 21 years ago, and we stopped it because, number one, it's painful, and number two, doesn't allow fractionation or division of the dose. We know that if we can divide up the dose of radiation, it's a lot safer. And what do most people want with a acoustic neuroma? Well, they want to keep their hearing, they want to keep their balance, they want to keep their face, they want to avoid radical surgery, they want to avoid the surgeon's hands in their head. I would too. That's why we developed this program. It's a unique program. We give the lowest biologic dose anywhere, and that's also a benefit for the patient. The patient asks, well, what do we do to help preserve his hearing and balance and face? Well, a variety of things. First of all, we have a whole team that works together. We've been at this for almost 25 years. Number two, we give the lowest biologic dose. Number three, we divide up the dose. He asked me, does everyone get the same dose? And the answer is yes. If you have the same disease, you should get the same dose, and that's why our data is so important. We have the largest experience in the world treating acoustic neuromas with non-invasive treatment. So this man came without his wife. I encouraged him. I actually told him to please, let's make a date that we all meet together so she can be part of the conversation and answer all her questions directly, and he liked that idea. So we're going to meet all together, and I told him that when you have an acoustic neuroma. Often the relationship, most of my relationships with patients goes on for decades, because people not only get the treatment, but then they get the follow-up, and it's very important to have good follow-up to know exactly what's going on. The follow-up, I believe, is as important as the treatment. There's only 2,000 acoustic neuromas diagnosed a year in America, so it's a relatively rare disease compared to, let's say, prostate or breast cancer, where there's 250,000, so 100 times more. So it's relatively rare, but we have a lot of experience. We have a lot of experience with many rare tumors and cancers, because we see so many people whose other treatment just didn't work. So if you're having trouble with hearing or tinnitus, you may want to get the best test. Is called an MRI with contrast of the internal auditory canals, and that test can best diagnose acoustic neuromas. Or you can come in, or you can give us a call, or if you want a booklet about brain tumors, we have a specific booklet, brand new, that you can call us during the work week, Monday through Friday, at 212-CHOICES, which is 212-246-4237. So again, this is Dr. Lederman from Radiosurgery New York, and we're talking about cases and news and taking your calls and helping, we hope, provide better health care for you, better information, better knowledge to deal with your doctors and others, so that you can have a better life and a longer life. We had a woman who came in this week, very interesting, 60-year-old woman, divorced, who had a liposarcoma. Sarcomas are cancers of the connective tissue, so we often think of cancers like of the breast or the lung or the esophagus or prostate, but she had a liposarcoma. Liposarcomas are of connective tissue, like of the bone and of the muscle and of the parts of the body that held together, kind of the foundation of the body. So in October 2012, she had a mass on her thigh. It was more than 5 inches, so pretty good-sized tumor, like a fist. She had an MRI. She had a biopsy. The biopsy showed sarcoma. She had radical removal of that. Now, the margins were only 0.5 of a millimeter, so just almost paper-thin margins. She was treated at another hospital for the surgery. Her tumor overall was 10.5 by 9 by 6 centimeters, liposarcoma. She had standard radiation, even though liposarcomas and sarcomas are one of the tumors that's considered radio-resistant. Radio-resistant means doesn't respond to usual radiation. So radio-resistant tumors include sarcomas, kidney cancers, melanomas. We know, by the way, they are very, very sensitive to focused beam radiosurgery. Radiosurgery gives a few treatments. She had 35 treatments elsewhere, low dose, but radiosurgery allows us to give higher dose, more pinpoint, and that's why it's more effective. So by summer 2013, a year later, she had pain in her inner thigh going to her hip and knee and difficulty moving. She was seen by orthopedics. They didn't do anything for 6 months, which seems strange because she had a cancer with paper-thin margins. And in December, she had an MRI which showed a mass in the left hip measuring 6 centimeters, which lit up on PET scan. So, wow, they did a biopsy which was negative there. But if you've got a mass and you have a history of cancer and the biopsy's negative, probably the biopsy was no good. So she saw her doctors in February 2014. By now she's using a cane to walk. She's getting worse. And they told her to wait another 4 months, which again seems strange because if you have a cancer and you have a mass, I think you'd want to know what exactly it is. So by June 28th, she had a new MRI that showed another mass, and that's when she now came to me. She came to me with that information just this week. So she had liposarcoma, thin margins, standard radiation, which you know is not very great. Now with mass, she came to us. Well, we arranged for her to get a biopsy immediately of that area because most probably she has a recurrence of her liposarcoma, her sarcoma. Our data for sarcoma actually shows more than 90% success rate. So radiosurgery is very different than surgery. Compared to surgery, our work is totally non-invasive. There's no cutting, no bleeding, no